Hey guys, welcome to our first day of online learning. We're going to start with mental health. This is a whole new world for all of us, me included. It's the first time I've ever had to video a lecture and it makes me super uncomfortable. But I do appreciate your kindness and your patience and your understanding as we get through an unexpected turn of events together. So I want to first start off with chapter 1. It is our intro to mental health and mental illness. As we go through this, you have your PowerPoints. I will refer to the PowerPoints as we go through, so if you see me looking away a lot, I am looking at my computer screen to make sure I'm on the right slide. So I will try my best to refer to the slides as we go through so you can keep on track as well. So let's just get started. We've got our 2 intro slides, and we'll start with slide 3 when we look at our definitions of mental health. So with mental health, this is defined by the World Health Organization, or the WHO, and by now you know who the WHO is because we see it on the news quite frequently. But the World Health Organization does define mental health as a state of well-being in which the individual realizes his or her own abilities, they're able to cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to one's own community. So when we look at mental health, notice it also says a complete when physical, mental, and social well-being are intact. And so with mental health nursing, we do hear a term oftentimes used called the mental health continuum, which is going to be where we have 2 polar opposites, mental illness and mental wellness. And not everyone is not always mentally well or totally mentally ill. We can see a fluctuation along that continuum. And that can change. That can change even day to day. Some of us may change minute to minute. But we do see that changes. And we'll see variations. Variations, as we see later on in this chapter, can be based on culture. So something that may be viewed as being a mentally ill activity or behavior in one culture or group may not be in another. So that's also something as we as nurses have to understand and incorporate into our nursing care is that cultural awareness. So when we do look at mental health, we do see its ability to function well alone or with others, ability to make sound judgments, accept responsibility for outcomes, and also one's own actions, and also to love, to be loved, and respond with humor even when life gets tough. And if these past few weeks has not tested your mental health, I don't know what else can. And a lot of us do respond with humor, and that is perfectly normal. Notice also in your book on page 2, we do see it goes a little bit deeper into that. Our ability to act independently, directed by inner values, strengths to face life with assurance and hope, seek a meaningful balance between work, play, love, and produce satisfying relationships with others. So we do see kind of how we've expanded on that definition of mental health. On to the next slide where we look at mental illness. And when we look at our definition of mental illness, it's a difficult one to define. It always has been and always will be. What is a mentally ill behavior for one culture may not be for another. Think of your age groups. A toddler that throws a tantrum, perfectly natural. An adult who may throw a tantrum may be a sign of a mental illness or something going on where there's an imbalance in their mental state. So when we do look at mental illness, we see a specific definition. This definition is going to be widely accepted. It's the DSM-5 definition, and that's the Diagnostic Statistic Manual. And this gives us our definition: clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychologic, biologic, or developmental processes underlying mental function. And that is a mouthful when we look at what our definition is. We can further expand on that definition with mental illness being a pattern of behavior that's disturbing to the individual, to the community. Behaviors of mental illness can interfere with their daily activities, meaning their work life, their social life, the ability to establish relationships with others, and also, as you know, mental illness can alter one's own reality. When we do see mental illness, no matter what, it will affect that person's ability to cope effectively with others and in their life, which can result in some maladaptive behaviors and therefore some impaired functioning. Notice we see that mental illness is usually associated with significant impact on the social, occupational, and other activities. When you look at some of your statistics, and it does get pretty lengthy in your book about your statistics, but notice 18.3% of Americans do have a diagnosable mental health disorder. And remember, this can range from, things like depression all the way to schizophrenia. So we do see a wide range of those. Serious mental illness diagnoses average 4.2%. And, this is kind of an astounding fact, the leading cause of disability in the U.S. So we do see a lot of disability cases that are related to mental illness. Next thing we look at is our cultural and ethnic and religious influences. So with our cultural variances, we do see that based on one's own culture, mental illness is going to be viewed differently, how we perceive it, and then also how the individual or that community copes and manages that mental illness. We'll talk a little bit more about the history of mental illness, and you'll see that with mental illness in different cultures, their beliefs and their norms may be a little bit different. So notice in your book that when we talk about the cultural heritage on page 3, culture is that term that describes a common heritage. It's one's beliefs, norms, values, behaviors that's unique to each individual culture. So with all these differences among cultures, there are going to be variances in how they deal with mental illness. Notice many families meet the challenge of a family member's mental illness by seeking professional care, but there is a stigma and shame still associated with mental illness. We may see this varied among different cultures as well, and even our own cultures. Remember, many times we use these terms like, oh, they're crazy, just so freely, that oftentimes we don't think about the significance of those terms. So I do advise you to think about that, and I'm bad as anyone else to say things like that. But when we think about our stigma, it is a stigma associated. And I've always thought of the analogies of, like, if you had diabetes, you would not be ashamed to seek treatment. If you have high blood pressure, you're not ashamed to take a medication for that. So I don't think that we should feel ashamed for mental illness as well. It affects more than you know, and we all have to be understanding to that. But as we look at some of our different cultures, they may differ from what we see in this westernized medicine of the United States. Our thought processes many times with mental illness is we see a physician, a psychiatrist, you get treatment, usually a medication, but a lot of cultures do not believe in the same way we do. Some cultures may see symptoms as a punishment for wrongdoing. Mental illness, you can see, is related to witchcraft, demon possession, even substance abuse. And some other cultures may turn to alternative treatments to treat the mentally ill, such as faith healers, and they may deny that those problems exist. You can also see traditional medicines and herbs used, rituals, religious rituals like prayer, touch, different herbs, roots, weeds used. So there's just a bit of a variety. And really what we want to see with this is just that we are accepting and we are understanding of those different practices. So let's move to our next slide, culture, ethnic, and religious influences, number 2. So like we said, some of those elimination strategies can include folk healing customs, magic, traditional medicine and herbs, religious rituals. And notice in many cultures, these traditions may be the first choice before they seek alternative care. Even though it may be available in their community, they may seek those traditional healings before they do what we think of Western medicine, whether that's therapy, medications, whatever. So let's look at our next slide, factors affecting mental health. So with mental health, we do see factors such as stress and anxiety playing a role. Stress and anxiety are unavoidable. They're just part of our day-to-day life. Notice also grief and loss can affect one's mental health. In our book it says the events that cause grief and loss are difficult to accept as a reality of the situation is imposed. When we are met with those stressors such as stress, anxiety, grief, or loss, it does upset that balance on that mental health continuum that we talked about previously. Notice each individual responds in different ways based on conditioning, cultural influence, the availability of mental resources. So, do they have that access to mental health care? What is their insurance status? Because that plays a big role in how we seek health care, whether it is for mental illness or any other illness. And notice it is our challenge as human beings to learn to deal with these issues in constructive ways. So next slide, we look at stress and anxiety. So with stress and anxiety, that can arise from any thought or issue that creates frustration or a feeling of uneasiness. When we look at our definition of stress, it is a condition resulting when a threat or challenge to our well-being requires us to adjust or adapt to the environment. There is a theorist, and it's on our next slide, Hans Sale, and I'm not really sure if that's the way you pronounce that, but that's the best thing I can do. And he really did a lot of studies on stress and the effects of stress on the individual. And then according to Sale, he did define different types of stress. So we have distress. So this is a negative type of stress. It occurs in response to a threat or a challenge. And this type of stress, especially over a long period of time, can be demanding and can exhaust one's energy. Then we have eustress, which is a good type of stress. This is a positive, motivating type of stress. It can enhance your sense of well-being, and it also is what makes you get up in the morning, makes you turn on your computer and listen to this lecture. So it's that stress that does make you act many times. And you can see some examples in your book how that he really defined and differentiated distress and eustress. We can also see acute and chronic stress. Acute stress, we do see with acute stress that it is a response to an immediate threat. So it may activate our fight or flight response. This is the time where we see that sympathetic nervous system kick in, that adrenaline start coursing through the veins, and we have that, immediate reaction, whether we either run or we stand there and fight. So we should be very well versed by now in that fight or flight response. This just heightens your awareness with fight or flight response. And it does cause us to act. Then we have chronic stress. Chronic stress is ongoing and continuous. This can be related to job difficulties, the loss of someone you're close to. And then when we look at stress, we can see common symptoms, and they oftentimes fall into different categories, such as physical, mental, emotional, and behavioral type of reactions. Notice the physical response to a stress is called a stress reaction. And when we look at some of our common symptoms of stress, you can refer to page 5 and box 1-1. And they really look at, first of all, some of the sympathetic nervous system, like the increased heart rate and blood pressure, heart palpitations, increased respirations. We oftentimes take deeper respirations as well. We can see other things, especially with chronic stress, like headaches, insomnia, decreased memory and concentration, and nervousness, irritability. And then you can see some behaviors such as fidgeting, pacing, nail biting, smoking, drinking, yelling, and throwing things. So those are some of our common symptoms we see of stress. Now, our next slide does look at Sale's theory. And like we said, it does, again, we see those definitions of eustress and distress, and also our stages of stress. So then go to your next slide. We see 3 stages of stress, and he called this the general adaptation stages. So first is the alarm stage. So this is the time we are first encountered with the stressor. This upsets our normal life. It upsets what's going on day to day. Upsets your homeostasis. So the alarm stage. Then we have the resistance stage where the body fights back as it tries to adjust to the stress. And then lastly, the exhaustion stage. So there's no rest. We can see the person become mentally and physically exhausted. So those are our sales theories of the general adaptation stages to stress. Notice on your next slide we see our physiologic stress response. Like we've already mentioned, the sympathetic and parasympathetic nervous system will control that stress response. So the sympathetic nervous system activates that stress response, the fight or flight response, and then over time, of course, we can't function with being in the state of sympathetic nervous system all the time, being stimulated. So the parasympathetic response will take over and then hopefully return to normal. Notice on your next stage, we do look at psychological stress response. And so these are often called the psychological first aid. They're used to maintain the equilibrium, lead to psychological growth. These are used short term, just like any first aid. First aid's not there to fix the problem. It's there to stop the bleeding, to prevent further harm. And so it is useful in the short term, but not in the long term. It can be dysfunctional and maladaptive. So moving on, we look at our next slide, which is anxiety number 1, and this starts on page 6 in our book. So anxiety is that feeling of apprehension, uneasiness. It occurs in response to a real or perceived threat. It is an automatic, unconscious, biological response. With anxiety, it is normal. It is a normal part of our day-to-day life. We do need that for survival, and it does provide enough energy in our life so that we do meet goals and pursue those goals. With anxiety, just like stress, it can be divided into different types. We have acute anxiety, and of course with acute anxiety it is short term, whereas chronic is experienced over a long period of time. And of course chronic anxiety can be exhausting. It can lead to problems like fatigue, insomnia, poor concentration, and also impair one's own work and social interactions. The severity of anxiety is expressed through an individual's perception and reaction to the stressor. And when we look at our different types of anxiety, we do have 4 levels. So that goes to our next slide. So there are 4 levels at which anxiety may occur. Mild anxiety, notice this is natural and motivating. We may see symptoms like increased awareness, increased energy, maybe some slight discomfort and restlessness. But at this time with mild anxiety, we are more aware, we're more alert to our environment, and we're motivated. So mild anxiety is natural and not always a bad thing. Our next level of anxiety is moderate. So with moderate anxiety, this uncomfortableness is going to increase. We're going to see the voice change. You may have tremors, increased speed of the speech, difficulty concentrating, shakiness, pacing. Notice misperception of stimuli. During this time, we may see decreased attentiveness, still functional, but the problem-solving ability may be decreased. And we may see decreased motivation and confidence and increased irritability. You may also, my nose is itching. We may see also occasional outbursts of anger and crying. Our next level is severe. So with severe anxiety, notice the patient may be physically, emotionally exhausted. We may have feelings of impending doom, confusion, increased somatic complaints. So somatic complaints means like your belly hurts, you have a muscle ache. It's like where a mental symptom manifests itself in a physical symptom. So we see that increase of those somatic complaints. Notice there may be loud, rapid speech, threats and demands, sweating, eye twitching, tremors. Psychologically, we may start to see a disconnect with reality. So they may start perceiving reality a little bit differently than they normally would. They may be defensive and oversensitive and may present with some verbal threats to others. And then lastly, we have our last stage of anxiety, which is panic. So during this stage, we may see hysteria, incoherent speech, even suicide attempts. These persons may experience feelings of terror, fear, out of touch with reality. Psychologically, they are irrational. Oftentimes, they have lost touch of reality and unaware of reality. Notice we may see some things like delusional thinking and disorientation. So those are our 4 different stages of anxiety. Next slide, we have the contributing factors to stress and anxiety. And this is going to be our external and internal stressors. Notice external stressors are things in your environment, which can be abuse, poverty level living conditions, your job, relationships, things like that. Internal stressors can be physical, such as a chronic illness, a terminal illness, psychological, such as continued worry about disaster or regarding financial issues. And, I have to think back to what we're going through with coronavirus. And can you imagine the amounts of internal stressors that we as a nation and individuals are experiencing right now with the psychological worry? So we don't know what's going to happen. I mean, we can look to other countries and see that what's happened in Italy, and that's sure not going to help with your stress level. So we do see a lot of those psychological stressors affecting us. Notice also we can see impact of personality type. And notice research has shown that heart disease tends to be more prevalent in people who are highly driven, competitive, ambitious, success-oriented, kind of that chronic hostile personality, or a type A. We do see stress affecting those more frequently, that type A personality, than one that is more relaxed and kind of easygoing. And then lastly, we see emotional triggers for higher stress levels. So that some of these events which are uncontrollable, repetitive, unexpected, or intense. You can see there in our book, it is important to recognize that many times we view external circumstances as a cause of our stress, but in reality we create most of our own stress by choosing to make ourselves upset. Monitor your anxiety-producing thoughts, your irrational thinking. That tends to take over, and we do tend to exaggerate things. This tends to give our thoughts an all or none frame of thinking, and that's a term we see a lot in mental health nursing, is that all or none framework. It's this type of thinking that leads to anticipating the worst possible outcome. And notice this is illustrated by an individual who is hit by the car behind him while driving in traffic, believing that if he drives the car again, he will have an accident, so they no longer drive a vehicle. Notice a major factor that does contribute to stress is the unpredictability of certain situations. A fireman, for example, faces uncertainty every time they do get that call. Notice emotional triggers for higher levels of stress are those that are uncontrollable, repetitive, unexpected, and intense, such as experienced by nurses in critical client care situations. So we as nurses do see a high level of stress, and you know that. I can imagine those that are actually working on the front lines in the hospitals are experiencing a great amount of stress just because of the uncertainty that they are facing. And notice as a nurse, and we see this all the time, there's a lot of nurses that just cannot stay at a job for a long period of time. We job hop. It's just something we do. And that is because the stress gets so much you just can't hardly take it anymore. And notice that term related to that is job-related burnout. And that is that complete mental, physical, and emotional exhaustion. And so we do see in the nursing field a high level of burnout. Next thing we look at, our next slide, is promoting adaptive coping strategies. So when we look at our adaptive coping strategies are methods that we use to deal with stress and anxiety. When we look at coping strategy, notice that the sense of control an individual feels over a particular stressor determines how they're going to think and perceive that stressor. The first thing we want to do when we are assessing a situation is to look at what it really seems to be. Sometimes that's hard, but sometimes we need to look at the situation and see what the reality of that situation often is. Once this has been determined, you can look at your options, they can be reviewed and help to resolve the problem. The solution may be one of trying to deal with the situation or one of controlling the emotional reaction. And you can see a little example in your book of how a student may deal with stress. So then when we look at our coping strategies, these are the methods we use to manage stress and anxiety. They generally fall into different categories, and notice they can be adaptive, palliative, maladaptive, and dysfunctional. So first of all, when we look at coping strategies, we do see those with positive outcomes, and that would be adaptive and palliative coping. Notice when a person uses a rational and productive way of resolving a problem to reduce anxiety, it's called adaptive. If the solution temporarily relieves the anxiety, the problem still exists, but we have decreased that anxiety for a time being, that's called palliative coping. And we oftentimes do that. We cope with something by kind of forgetting about it for a little while. The stress is still there, but we'll think about it later. And that's palliative coping. These two types of stress typically do result in positive outcomes. Then on the opposite end, we have those that produce negative outcomes, and that can be maladaptive and dysfunctional coping. If unsuccessful attempts are made to decrease the anxiety without attempting to solve the problem, the strategies are described as maladaptive coping and the anxiety remains. The individual who does not attempt to reduce the anxiety or solve the problem is considered to have dysfunctional coping in response to the stressor and the emotional response. And you can also read over a couple of those types of situations or examples that illustrates those types of coping. Then when we look at promoting adaptive coping strategies, that's our next slide, and I'm looking outside because it's coming a monsoon out there. So next thing we look at is promoting those adaptive coping strategies. So we do have some ways that we can promote effective coping and how that we can deal with stress. And you can see those in your book as well. But positive self-talk and reframing irrational thinking. Reframing is a term that we do use a lot in mental health nursing. So notice reframing is a way of restructuring our thinking about a stressful event. So it's just kind of changing our thought process. Notice you have a table 1-4 at the bottom of page 9 about how to reframe irrational thoughts. So just take a little time, and I'm not going to read every one of those, but take a little time to read them and actually think about what they're meaning. So, a good one. He never does what I want him to do. Let's reframe that. If I want him to do something, I need to communicate that to him. So we do see some examples there of how to reframe some of our irrational thoughts. And a lot of times, irrational thoughts are going to have these terms like always and never. Because very rarely in our lives is anything ever always or never one way or another. So we can also see some of our other effective techniques for managing anxiety, such as assertiveness training, problem-solving skills, communication skills, conflict resolution, relaxation techniques and meditation, support system. Something's bothering me in here. So anyway, support systems, practical attitudes, sense of humor, self-care, which includes diet, exercise, sleep, avoiding stress-increasing substances like caffeine and alcohol, and faith in a spiritual power and in yourself. Okay, next slide we see is ways to deal with stress in a healthy way according to the CDC. And these are just some things that we pulled off of the CDC's website, and you can read over those. There are a lot of common sense things, but in a time that we may be faced with the stress, common sense may not be prevalent. So those are just some little tips, and you can read over those. Our next thing we look at are some of the maladaptive, not helpful reactions to chronic stress. So these are some of the things that we see, or sometimes we may even do, that are not effective with stress, such as drinking alcohol to relax, using tobacco products, working all the time, procrastination, altering one's sleep pattern. So those are some of the things we see that are not adaptive. Okay, next slide we see is grief and loss. So again, we are faced with some definitions first of all. So grief is the emotional process of coping with a loss. Notice instinctively we associate that with the death, and that could be a death of a loved one, a spouse, a pet. But in a broader sense, it can be the loss of anything. It can be the loss of a situation. It can be the loss of a body part, a threat to one's health. So, loss is just it varies. A loss to me may not be a loss to you. So we have to kind of think of that as we go through nursing. And then we do see our definition of a loss. It's an actual or perceived status change in relationship to a valued object or a person. And you can see some examples like not receiving a promotion, academic failure. No one died there, but that's still a very significant loss, and it can leave you with feelings of grief as well. Then we look at our different types of grief. So, different types of grief, anticipatory grief, and that's just like the word sounds. It's when you expect something. You expect a major loss. Those that have had a terminal illness, a change in the body function. Sometimes with anticipatory grief, it is beneficial. It helps you to adjust and kind of go through some of those stages of grief. Notice the nurse can apply this concept to those in acute care who may be anticipating the loss of a body part or change in body function as well. Conventional grief, this is grief followed by experience following a loss. This process is called bereavement, and it's a period of adaptation. And again, bereavement, we get 3 days off of work many times is bereavement, but there's no set time that bereavement does occur. With a bereavement, it can take days, weeks, or years depending on that person and the sense of loss that is experienced. Children and adolescents will respond according to the level at which they understand the concept of death and loss. And you can see in your book, Table 1.5, we do see some of those different concepts. Notice a toddler is egocentric, so they think about themselves. They're concerned with themselves and do not understand the concept of loss. Preschoolers are still engaged in magical thinking and may feel shame or guilt associated with the loss, and they oftentimes believe that it is their fault or they're to blame for a loss. The school-age child can still feel some sense of guilt. We'll talk more about our theorists, but you can also see that with the school-age child, they're very concrete. They like to have facts. They want to know exactly what's going on. They're not really able to think kind of outside the box, so they do respond to concrete, simple, logical explanations of death. But they do understand the permanence of death, and that is not just a temporary loss. And then an adolescent is able to understand the concept of death, but may have difficulty accepting that loss. Next thing we see is grief as a process. So when we look at grief as a process, this is a series of occurrences in the resolution of loss, provides support while working through feelings of loss, anger, hopelessness, futility, fear, and guilt. With the grieving process, it does provide time to put events into perspective, place lost things into memory, and emerge with newly developed embrace for life. Adapting to loss is a learning process, and accepting loss as a part of life. Learning to deal with loss is oftentimes better dealt with in small increments than a large chunk at one time. Learning to cope or adapt to loss involves giving ourselves the right to grieve, and it's important to recognize and accept the feelings of loss. And so one of our most important figures in the theories of grief and loss is Elizabeth Kubler-Ross, and that's on your next stage. She described the stages that a person who is facing death encounters before coming to the final acceptance of the death. But with the stages of grief or the stages of dying, that really can apply to many situations and not always just a death. So it can apply to many other losses as well. So we should know these by now. I know you've heard of them before, but remember the acronym DABDA, D-A-B-D-A. So they are, first of all, denial, which is shock and disbelief. Notice that denial, we may want to avoid the reality of the loss, act as if nothing has occurred. And denial actually does have a purpose. There's a reason for denial. It allows an adjustment period in which to gather coping strategies for your grief work ahead. Then we have anger. This is realization of the loss. So anger is expressed in many ways: crying, self-blame, guilt. Anger is usually followed by bargaining. So bargaining is the attempt to postpone the acceptance of the loss, oftentimes seen with a terminal illness. And we do see that where patients or family members may try to make deals with God or whoever their higher power may be. So you may see things like, oh, well, if I can only live to see my son graduate, if I can only live to see my daughter get married. You do see some of those type of bargaining attempts for that loss. Notice the bargaining period is gradually followed by a deep sense of loss as the reality of what has happened settles. Persons may withdraw from social interactions, spend time alone, and this stage is the depression stage, where they may enter a persistent, prolonged mood of sadness. But notice it is a normal response to loss. And notice depression is defined as that prolonged mood of sadness that may extend beyond 2 weeks of duration. Then our final stage is acceptance. This is where the person begins to experience peace and serenity. It is a time of letting go and allowing new experiences and relationships to develop. With your stages of grief, a person may not all the time make it through those stages. They may get stuck in a stage, and they may go back and forth between different stages. The next slide we see is dysfunctional grief. So with dysfunctional grief, notice that is a failure to complete the grieving process and successfully cope with a loss. If the person does experience a prolonged and intensified reaction, life may become meaningless, and existence is centered on longing for that which is lost. These extended feelings a person has while attempting to deal with the loss are described as chronic sorrow. Unresolved grief describes situations in which the grief process is incomplete and life is burdened with maladaptive symptoms. This can continue for months after the loss. And notice some of the factors that can contribute to unresolved grief may be things like a socially unacceptable death, like a suicide or a homicide. A missing person, notice whether that is missing due to war, a disappearance, there's just no closure for the ones left behind. Multiple losses in a short period of time, and that may be death, it may be loss of a job, financial losses, lots of different things. Ambivalent or unresolved feelings for someone that is lost. Guilt associated with circumstances at the time or near the time of death. Survivor's guilt, which we've probably all heard of before. Feelings of worthlessness. Physiological responses to the loss with decreased functioning. And delusional thinking or hallucinations. And you can see those that we went over do cover your next 2 slides of dysfunctional grief. And so the last thing we look at in this chapter is coping with grief and loss. So notice that the coping with grief and loss, because of the intensity of the feelings at this level, the person is often desperate to, and they oftentimes will seek some clinical attention and treatment. To deal effectively with the client experiencing grief, the nurse must face the reality of their own mortality. And that's another important thing when we think about dealing with those with mental illness, is we've got to realize our own mental state and our own limitations and how we feel about certain things. So that's important, not only with grief, but just dealing with mental illness in and of itself. Notice most people experiencing crisis of major proportion require assistance and support to complete the grief process. The nurse needs to respect and attempt to understand the importance of grieving. Hold on 1 second.